Thanks very much, Helen, and welcome everybody. And again, just like to acknowledge the traditional owners of the lands that we're on. So this is a soothsaying session, so we've got 4 top well-renowned soothsayers to tell us what's going to happen over the next decade or so. And as Helen said, it'll be a Q&A. We don't have any predetermined path about where we should end up by the end, at the end of this session, but we very much welcome a lot of interaction with the audience. So I'll introduce the panellists, and if they could come up whenever they want, really. The first is Professor John Karnon, who has a broad area of expertise in the economic evaluation of healthcare services and technologies, with a focus on the use of mathematical and simulation modelling methods to synthesise data. He has worked with governments, health services and pharmaceutical companies to inform decisions regarding the value of new health technologies and models of care. And we heard quite a lot about low-value care yesterday, John, so that's very timely. Also an Adelaide resident, I should point out. There's a strong Adelaide theme through here, which excludes me. Then we have Professor Michael Kidd, AO, very well known to the audience, I'm sure. And Michael's Director of the Centre for Future Health Systems at UNSW and Professor of Global Primary Health and Future Health Systems at Oxford. He served, as we all know, very well and diligently as Australia's Deputy Chief Health Officer during the COVID pandemic. Not an easy gig, and congratulations again on the great job you did there. Next we have Gillian Mason, who is the Head of Research Programs at the National Disability Research Partnership. Gillian's got 2 decades of experience in healthcare and health and medical research sectors, as a clinician, as a physiotherapist, as a researcher and a consumer representative, and she has lots of experience from the consumer representative side, working with governments and other agencies. And last but not least, we have Professor Steve Wesselingh, well known again, further Adelaide connection, who's CEO of the National Health and Medical Research Council, former president of this academy, a clinician scientist of renown, as we all know. So thank you very much, all 4 of you. And I might perhaps open proceedings by asking you all to embellish those snapshots of your CVs with perhaps a comment about what's keeping you up at night right now in the context of where are we heading for the next 10 years. So maybe I'll go from this side to yours. Steve, could you go first?
Thanks. This is on. Thanks very much. And I'm really looking forward to this session and interesting to hear everyone's ideas. I guess from a funder, we look at this, I guess, from 3 points of view in terms of trying to predict the future, which is obviously a difficult thing. One is that are we funding the right things that are going to allow us, particularly Australia, to lead in the areas that we need to lead? And I do think, this does keep me up at night, I do think we tend to be very safe in our funding, very conservative, and perhaps lack the abilities to identify the truly innovative opportunities that should be funded. And there are some examples around the world where I think this has been done better. I think the one that people often quote, unfortunately it's a defence organisation, but DARPA in the US, which really has generated a lot of really innovative science. But the UK has now followed that with AHRA, which is the Advanced Research and Invention Agency, and put $800 million into that. And the Wellcome has developed LEAP, and they've put $600 million into a totally separate part of the Wellcome Trust that only looks at really innovative, really risky, high risk, high gain type research. And I do think as a country and actually as a funder, we probably need to think about high risk, high gain research if we're really going to deal with the innovations that have been highlighted over the last couple of days, and I'm sure the panellists will highlight. So are we funding the right innovation is the first thing. The second thing is that as innovations come on board, and because we're a funder and look after things like integrity and ethics across the country, do we have the right frameworks in place for those innovations? So integrity and ethics is a really important part of that. And I guess the example I would use there is mitochondrial donation, where we had the innovation and the science and the technology for quite a while, but it took us longer to get the ethical frameworks, to get the social license to enable mitochondrial donations than it actually did to develop the science. And so, but we did that, and I think that's a really good example of an innovation that now is having an impact. And then lastly, at NHMRC, we like to ensure that we look at everything through an equity lens. And I think there's a real danger that any innovations that we look at will increase gaps rather than decrease them. And I think a lot of cancer therapies are good examples of that, where people in the metropolitan areas are getting those cancer therapies which aren't necessarily available in rural and remote areas. So if you're close to the Peter Mac, you're probably going to do better than if you're close to Alice Springs. So we need to make sure that if there are innovations, that we look at it through an equity lens and that everyone in the community can benefit from those innovations, and we don't increase the gap between those who have and those who don't have.
Thanks, Steve. Gillian, what keeps you up at night?
Yeah, it's a great question, and those things would keep anyone up at night. So I think I should talk a little bit more about my positionality before I tell you why things are keeping me up at night. So yes, I'm a clinician researcher, and also for various reasons, some of those being that it's really difficult to follow a traditional research career path if you live with disabilities, if you're a single parent, and so I'm not asking for anyone's pity here, but I look like a white, well-educated, middle-class woman, which I am. But also I'm queer and I'm disabled, I've got multiple chronic conditions, and I cannot tell you how many invitations that gets me to be a consumer rep on people's research the night before it's due. But so I'm experiencing medical research sector on both sides of the bedside in genuine ways, and what is keeping me up at night is how different it is depending on which side you're on. So I think we've got this huge opportunity to actually leverage the community knowledge and the knowledge of the systems as well as the health conditions that people have a lived experience of. I mean, we can take the lead from our First Nations research groups and community leaders on the way that they've been working for 60,000 years. And in that, in experiencing being invited into or leading research from both sides as a consumer leader and a clinician researcher, I am worried that what we're going to do with the advancements we've made in centering the consumer in all ways is we're going to only allow that in a way where we assimilate people who live very different lives, speak different languages, have different priorities. We'll allow them to be included but only if they will come and work with us in meetings and in ways that maybe don't serve us very well anyway. I'm worried about that. I think we can be much more creative and draw on other industries and other settings where collaborative work looks differently. I think we can do it much better and make sure that we've got access to and we're using the knowledge that just exists in the community, and we don't get too stuck on things that we can probably talk about later, but tokenism and centering a patient, maybe we can just collaborate better.
Michael.
So since I stopped working for the government late last year, I'm actually sleeping a lot better. But there's still things that worry me and concern me. I loved your description of us as soothsayers, John, because my new role is as a health futurist. So I get to look in a crystal ball and think about where our health systems might be in 10 years, and indeed what research do we need to be doing now in order to get there, and the work that we need to do with our policymakers. And there are things which concern me about future stresses on our health systems, the impact of climate change that we saw yesterday. How well are our health systems preparing for climate migration, increasing heat stress, more environmental emergencies? How well are we preparing for the ageing population and indeed the increase in the size of our population? And how well are we learning the lessons from the COVID-19 pandemic and applying those into our health systems reforms both here in Australia and around the world? I did want to just say one thing, though, about COVID-19, and it's to say a huge thank you to everybody in the room for the many contributions which the fellows of this academy made throughout the COVID-19 pandemic. I had the privilege with one of our foundation fellows, Professor Sharon Lewin, of chairing the National COVID-19 Health and Research Advisory Committee. Quite a number of you were part of that committee and supported it. But the Academy was incredibly up the front helping with that work, particularly represented through our then President Ingrid Scheffer, and coming together every Wednesday to support developing the evidence base to assist our Chief Medical Officer, the Australian Health Protection Principal Committee and the Minister for Health with evidence-based decisions based on the research for many of the policy challenges that we were facing. So a huge thanks to all of you, but a huge thanks to the Academy. I think showing the value of the Academy in that way was incredibly important as well in demonstrating to our government why it is so essential that we have wonderful groups like this. So thank you all.
Thanks, Michael. And John?
Thanks. Yes, so as you can see, I'm a health economist. So my day job over the last 20, 25 years has been doing economic evaluations, and a lot of those have been of new health technologies, mainly pharmaceuticals, but screening technologies as well have been a key part of my career. Another relevant aspect is that I was a member of the Economic Subcommittee of the Pharmaceutical Benefits Advisory Committee for more than a decade, and so as part of that committee I got to see how these technologies make it into the health service, and the dilemmas, the uncertainties, the challenges around making decisions, making recommendations about whether new technologies should be funded. And that led to a particular interest of mine, which was around estimating the opportunity costs. So we always talk about the costs of new technologies, but when we're making decisions about whether to fund new technologies, what's really important are the opportunity costs. What are we giving up in order to fund new technologies? And so we had a lot of research trying to estimate those opportunity costs to inform those types of decisions. And so clearly, as a health economist, you'd expect me to say, I'm concerned about the cost of all of these technologies that are coming down the pipeline, and obviously we're seeing some of that now. But I'd also say it's not just cost, it's also the integration and capacity to adopt technologies in the health system. So I've been involved in the National Lung Cancer Screening Programme recently, and all the plans for that. And just this week, all the states came together with the Commonwealth government, and it was really interesting to hear about all of the issues involved in implementing such a program. And clearly, National Lung Cancer Screening Programme is a big program, but it's a relevant issue for a lot of technologies as they come into practice.
Okay, thanks very much. Now, do we have any burning questions from the floor, or I might start one off? And Steve, you hinted at one of the things that was involved in keeping you awake at night, and you talked about the mitochondrial work, and that was an example, and I was on the NHMRC committee that looked at that, and it was an eye-opener for me just to see the rigour and the enormous amount of work that went into it, but also how long it took. And are we missing the boat in times where we've got new technologies coming down the pipeline very quickly? John's described some of them. We talked about AI yesterday, and we're not ready for those things at a legislative sense. And could we perhaps get, maybe as an academy, or get a little bit in front of the game? Could be a bit more proactive about getting ready, helping the community's thinking be ready. And I value your contribution, Gillian, obviously. So that there's a bit of forewarning that we suddenly aren't hit with ChatGPT with nobody really knowing how to use it, what its implications are, what the costs might be, not just in terms of dollars, but in other costs of wrong information, etc. So can we be better at predicting what's happening from a legislative perspective, from a community, education perspective, and a professional education perspective, I guess?
Yeah, absolutely. And I don't think we're very good at all, really, at doing that, at predicting what's coming down, and then putting the necessary effort into being ready for it. And I gave mitochondrial donation example, but I think even mRNA vaccination was an example where Australia wasn't necessarily ready, and the community also wasn't quite ready. I think, looking forward, things that are going to come forward, quantum sensing, synthetic biology, living machines with stem cell and other neural stimulation. I mean, all of those things are already in the journals, already being published, and yet we're not having the conversations about how we're going to utilise them in our health system, how we're going to work with the TGA, as an example, to get those sorts of things approved. and what are the ethical and community concerns. And again, I think we're writing a consumer statement at the moment at NHMRC, and part of that statement will be about having consumers involved right from the very beginning of any research development. So asking firstly whether consumers think the ideas are good and will meet a need, but also then working with the consumers to understand how it's going to impact on their lives and what are the things that would concern them and keep them awake at night, so that we can address those at the beginning or through the pathway of development rather than at the end, which we often do now. So we often develop something and then we say to the consumers, you know, what worries you about this? But, you know, there's no opportunity to change at that point.
So Gillian, tell us how we should be doing it.
Well, I definitely don't have all the answers. I've got some good news, but just a reflection. So I was involved in pulling a lot of people together to give some input on a response to the consultation on the new consumer and community involvement statement. And I shouldn't say shocked, but I was very interested in how few researchers had read it. Which I expected that I'd be spending a whole lot more time upskilling the consumer representatives I was working with and some community members who I deliberately talked to because I thought they'd been participants in research, but they might know where to find these things. Yeah, mostly the consumer representatives were across it because we had supported them to know what they were doing, and many researchers maybe knew about it but really hadn't read it. And so whilst I'm sure that, and already now, if you look at what's in there, it should tell us what to do. You know, everything needs an update, but what's in there already, had we have been following these guidelines, we should have excellent research that is community-led and that is fast, you know, that actually gets into action if we've designed things in a great way. So I'm thinking about what can we all do to make sure that the words on the page get into action, and I feel there's investment that's needed around that, but I don't, you know, I'm really hopeful because we can solve really challenging problems, right? And we've got expertise in implementation science in lots of ways and communication in our research networks. So that was just a reflection. Most of the researchers who we involved, there was selection bias around that too, because they were people who were interested in contributing to this consultation, hadn't read it before. We had a broader conversation here about making sure that the community is ready, or that we're all ready, and how we can know what the community is thinking or knows already in advance to support new regulations being created. Is that where we were?
Well, I think really not surprising the community with an end product maybe is a very succinct way to put it. And you know, we know things are coming. How do we ensure that the community is informed about those before they come, and how do we ensure that the clinicians or the people that are using that tech or whatever it is also informed about its use and pros and cons of its use? But mRNA vaccines was a great example where both the average clinician and the average person in the community had no idea what this was all about, didn't really understand it, obviously was a little concerned. So is there, you know, how do we engage the community in something that's probably not going to hit them for a couple of years, but that they would benefit from knowing a little about?
Yeah, others will have a view, so I'll try and keep it brief. But what's worked really well when I've been involved in Centres for Research Excellence and research institutions is where there is all the time, not just when we need something, an all the time way of being engaged with the community. I think we need to be better at hanging out as humans with people and just knowing what is life like for people who live with the conditions that we're researching or access the systems that we're researching or live in the communities that we're trying to improve the health of. Like we need to, I think it's more about a mindset and a culture issue than a how should we do it issue, because I feel like we'll work that out. But changing our mindset so that we're thinking about the community and consumers as part of the team, that we're all in this together, like part of the team making the discoveries together with us, rather than only the recipients or end users, especially when we're talking about communities who are experiencing the worst health. If we only think of these people as vulnerable communities, and this goes back to kind of how I feel and how I am treated when I'm a consumer representative and kept at arm's length and taken care of with an assumption of vulnerability, rather than where it works well, I'm considered as part of the team, even if my role is really small, treated with respect. And there's an assumption that we have a reciprocal relationship and there's knowledge to be shared both ways.
Okay, thanks. Michael?
So I'm really pleased we're having this session as part of the Academy annual meeting, because I think there is an incredibly important role for our Academy in predicting what's coming down the track and getting the early discussions happening, starting the discussions with government, starting the discussions, the public discourse with the people of our nation. COVID-19 hit and it was blindsided huge number of people, but many people in this room, of course, knew that this was going to happen. It was just a matter of when. Fortunately, we had people like Chris Blythe, like Lynn Gilbert and others in the room who were ready to step up and support government and make sensible decisions. One of the great examples is AI and looking at how AI is going to impact on healthcare. One of our fellows, Enrico Quira, started the Australian Alliance for Artificial Intelligence in healthcare about 8 years ago, got academics, industry, governments together, produced a fantastic framework saying we need to be ready for this, we need to think about regulation, we need to think about ethics, we need to think about the safety and quality implications, as well as thinking about the applications in healthcare. That was in 2019. Absolutely no traction with government in having any interest in any of that. It was only last year. All of a sudden, everybody's talking about it. Oh, and we need all these things which had been predicted were needed 5 years ago, and we could have been having those discussions then. I think that getting the Academy to pick up things like that and go to government and say, we need to be investing in this right now and getting the thinking right is something really powerful that we can do together to support the nation.
Thanks.
That's essentially, so yeah, building on that, Michael, so as some of you may know, there's recently been a full-scale review of health technology assessment processes in Australia. And part of those processes is an activity called horizon scanning, and I'm sure many of you have been involved in that process, but the review found, which it wasn't a secret, that Australia doesn't have a national horizon scanning process in place, that those processes have been kind of degraded over time. Maybe that relates to the impacts of AI, but one of the recommendations is that there should be a national horizon scanning process in place. And I brought a little prop, which is a report that was published in May this year about emerging health technologies to kind of demonstrate the value of horizon scanning. And so this focuses on technologies that are in clinical development, so it's not going to preclinical development. But clearly that's where the members of the Academy should be engaging with government through this horizon scanning process. So if that is put in place, I think that would be very useful as a mechanism for identifying things in the pipeline.
Yeah, go, Michael.
Just if I can add in, I totally agree. I've noted through my time in government that Australia's chief scientist does quite a lot of this and does it with the Academy of Science. Kathy Foley recently has been doing a series of forums around the country on quantum technology and how it might be incorporated in different industries, including in health, and producing a report for government along those lines. And it'd be great to see this Academy having a similar partnership with our Chief Medical Officer and our Chief Nursing and Midwifery Officer and our Chief Health Economist and others to do that sort of horizon scanning and prepare for the future.
Okay, thanks.
Just thought to add, so the recommendation was to develop horizon scanning capacity, but they also emphasised that it had to be carefully designed. And so I think the scope to contribute to that design process.
Brilliant. Yep. We have a question, Layla. Sorry.
Hi there, Deborah Lupton from UNSW Sydney. I'm just wondering, given that the COVID pandemic has not gone away and we're still getting multiple waves, people are still being badly affected by it, getting sick. Healthcare workers have become disabled by long COVID. I'm just wondering what the panel thinks about what future research into better mitigations against the spread of COVID might be in the next decade, and also about research into long COVID, which is disabling more and more Australians. every day as they get more infections with COVID? Thank you.
Who's going to pick that one up? It looks like a Michael question to me.
Well, happy to start, but I think we're all invested in what's continuing to happen with COVID-19. Of course, we all know family members and friends and colleagues who've been impacted by long COVID as well. I think it was encouraging to see the Medical Research Future Fund come forward with some very substantial investment into looking at long COVID, and particularly into the diagnosis and management and multidisciplinary team-based care approaches which are needed by many people. So it's good to see some research investment happening there. I think also with regard to ongoing impacts of COVID-19 and other infectious diseases, we've all been holding our breath until we go blue, waiting for the Australian Centre for Disease Control to finally come forward from its interim status. Hopefully we'll see something positive happen, at least in the lead up to the federal election with that entity coming forward. A big focus of the work which has been happening with the ACDC has been around data and surveillance and streamlining what is collected in the states and territories and reported through to the Commonwealth, which is very important. But there's a lot more which needs to be done, and I'm sure there's lots of people in the room who have views there as well.
I'm happy to comment with a few hats on. So I worked as a physiotherapist in one of the COVID care in the home services, and where I thought most of that work would be difficult in terms of thinking about chronic complex health conditions and what might actually clinically happen next for someone in a tricky situation, but 99% of the work was addressing misinformation and disinformation, and that has lots of reasons. There's lots of reasons for that, but that has lots of impacts. That had a direct impact on the clinical care that I was able to provide to the people during their calls, which I think that's something kind of that's not being acknowledged. And absolutely, we need to be looking ahead and establishing these formal, really important structures and CDCs and investing in research that will discover new ways about preventing new mitigations, new treatments. But in the meantime, I feel like we need to be doing more and tapping into the expertise of the researchers who are looking at how misinformation and disinformation are having impacts. So on the one hand, I feel like there's bigger impacts on lots of things than we want to recognise, and we all could actually do something about this. We've got expertise. And then living through the first couple of years of the pandemic as someone who was quite severely immune compromised, and then trying to figure out how do you kind of live in this world where, we are all still very at risk. There's much to be done about gaining public trust and gaining consumer trust in order to be able to do really meaningful research about long COVID or meaningful research about anything mitigations. You will be hard-pressed to find consumer representatives who have a lived experience of long COVID, who are interested in being involved in research, who haven't been forced to actually end up being more of an advocate or activist than they would like to be. So I feel like there's actually a lot that we need to address really urgently about regaining public trust, understanding what the lived experience is of long COVID and kind of more broadly the health system impacts. That's like a lot of challenges, but also I feel like a lot of that could be easy to do because there's great science around how do you build trust. But it's just a matter, I guess, of who was going to take the responsibility on or pay for that. I don't know what the answer to that question is.
Steve, could I... Oh, you were going to do it anyway. Yeah, go ahead.
Yeah, I'm very happy to comment on that because I do think it's a really, really important issue and have spoken publicly about it recently. But losing trust in science, I don't think that's happened in Australia yet, but it clearly is happening in other countries that we can point to, one that's just having an election right now, where people are clearly just spreading misinformation, disinformation, basically lying, and not necessarily being held to account. I do think that is already happening to a degree in Australia, and obviously COVID played a bit of a role in that. And as an example, there are people and politicians who are happy to make statements about Australian scientists and their roles in the origin of COVID and arguing, I think the origin of COVID is pretty clear now. The really good Cell paper came out recently, yet we hear people talking about Australian scientists and their role with Fauci and others, and clear disinformation. And I do think organisations like the Academy and the NHMRC need to ensure that that trust in science is maintained. And we need to do that through having, high quality information, high quality scientists and high quality science to continue to reassure the community that we're there and that we're there to help them in those regards. And I think if we do lose the trust of the community, we'll lose the social licence to do the research we do, and that, would be dramatic, I think.
Well, one more comment that maybe is actionable and quite practical coming down one level. I feel like now there's trust to be built by taking evidence-based actions now when we're bringing people together. So I've been invited to things where, as someone who at the time was severely immune compromised, invited to a forum, a medical forum with researchers to talk about how we need to protect vulnerable people in the next pandemic, and how, it was a conversation where evidence was being presented, held in a room with poor ventilation where no one was wearing respirators at a time when we were actually kicking off and our hospitals had gone into different settings because the local situation was a cracking COVID wave. I feel like we absolutely need the higher level trust in and social licence pieces happening, but there's lots of things that we can do to be going, okay, we're going to apply the evidence that we have now and create safe spaces for the people who are affected by these things more than others right now. Those things are easy. It's just annoying to do it, but if we're not leading by example, like this venue is fantastic, but this is not normally where these kinds of things happen at our local level in our local hospitals or institutions. So there is a lot of trust being eroded, probably accidentally, by researchers and clinicians who are, I guess, really forcing people to see a situation where lots of people aren't applying evidence. So that's hard then to trust that that information is right.
Steve, I think sorry, I'll come to you 1 minute. It's a great question, but it highlights potentially from an opportunity for the funders. You talked about it'd be great to have this, high risk, high yield pot of money. What we're talking about here potentially is a rapidly responsive pot of money. The merger, if I'm allowed to call it that, marriage, prenuptials, I'm not sure where you are with MRFF and NHMRC, but you've got a new committee structure. Is there an opportunity then to have a pot of money that is there for new stuff? Because we didn't know about long COVID, and so is there an opportunity to do things differently for the next 10 years in the way we fund?
I think there is. I think it was clear from the public consultation or the consultation of the sector that bringing together the MRFF and the MREA, or the fund that NHMRC has control of, was highly sought after by the sector, but they did want to keep both funds available, and I think the reason for that is that the MRFF is a priority-driven fund, and it is a little more flexible than the MREA. So the fact that we're now working quite closely together, although not totally unified, has allowed us to identify more quickly ways of funding acute need. And I'm actually quite excited about the next couple of years where we'll have both the MREA and the MRFF working together. We can use the MRFF as the priority-driven fund, the MREA to drive things like investigator and ideas. Yep. But it also then gives us at NHMRC a bit more flexibility with our targeted calls for research as well. So yeah, I do think we need to be a bit more responsive, we need to be quicker. And I do think, honestly, and we are thinking about it, ways, even though we don't have the $600 million that Wellcome have to put into high-risk research, we should think about how we can be a bit more responsive and have schemes or change our current schemes so that we are funding some high-risk, high-gain research in Australia. And I do think that's a gap that worries me a lot.
Yep. So I'll go to John and then to your question.
Thank you. Benjamin Kyle, Executive Director of the Garvan Institute. I've got a comment and a question. The first is that the comment is in response to Gillian's points about, for example, consumer engagement, and I totally agree with you, Gillian. I just put the perspective that as an institute director, it's a resourcing issue. So many of our people totally agree and are on board with a consumer engagement philosophy, but finding the resources to support that engagement is really tough. And the broader point, I guess, is that when the NHMRC puts out guidelines like on research integrity and scientific best practice, etc., we're on board. We're absolutely on board. But the resources required to actually make those things happen and put those changes into train is really tough. So I don't want the sector to be characterised as disengaged and disinterested. We aren't at all. It's very much a resourcing issue. It's not the only issue, but when you've got success rates under 10%, particularly in basic science, our researchers are absolutely screaming. And the idea that I can then say, listen, I need you to take a lot of time out and engage with this new initiative from NHMRC, it's tough to get that engagement. So I don't think it's a values problem, I think it's partly a resourcing issue. Which leads me neatly to a question for Steve, and that is the health and medical research strategy, Steve. What can you tell us legally? And what are your hopes and aspirations for what this might look like? You've talked about MRFF and NHMRC. Garvin put in a submission. We're of the view that the two things should be merged because it shouldn't be beyond us to actually have one scheme that's coordinated, and obviously the strategy is key to that. So, Steve, what can you tell us, and what are your hopes and dreams for what that might look like, and what we might do differently to enable the sector in Australia?
Yeah, I actually honestly believe that the writing of the National Health and Medical Research Strategy is a real opportunity, and obviously an organisation like the Academy, but lots of other organisations, AHRA and others, need to be intimately involved. We've actually never had a national strategy for health and medical research. We've had a couple of really good reviews, the Wills Review and the McKeon Review, worth still having a look at the McKeon Review because a lot of good stuff in there that was never done. But I think it's an opportunity, and I think I think a lot of the things you talked about are that we're doing lots of the right things, we just don't have enough money, and that's I think very true. The sector is underfunded. It's underfunded in terms of indirect costs. It's underfunded in the size of grants that we give. We know that our grants don't pay for everything that someone wants to do, and the success rate is way lower than we'd like it to be. So yeah, if I had a plea, double the amount of funding that the NHMRC gets, that's what the Wills Review did, and we probably need to do that again. So I think the strategy needs to be developed in a way that we highlight that health and medical research, the research is the answer to the challenges that our health ministers and our health system is facing, the things that John talks about. Our health system is facing lots of challenges, but the answers to those challenges aren't, sorry Michael, in the offices in Canberra, I know you're not there anymore, but that they are in your hand. The answers are in research. We need to develop those answers and meet those challenges, and that needs to be very strongly articulated in the strategy, that the research will be the pathway to dealing with I know it's hard to convince the CEO of a hospital that the emergency department congestion in her hospital is going to be answered by research, but it is. The answers are, it's not going to be answered by moving beds around or moving ED physicians around. So I think that's where I'm hoping the strategy will go. And then we put enough hooks into the strategy that require governments to fund more research and more development along that pathway all the way to improving our health system.
Thanks, Steve. Now, John, you had a comment earlier that you wanted to make.
I was just using the previous question around long COVID as an example, and Steve talking about investing in high-risk, high-return research, that to me, therapeutic research into therapeutic responses to long COVID are probably not the kind of thing that NHMRC should be necessarily funding, because there's huge incentives in place for private investment to address those types of questions, and so that's the kind of thing you should be thinking about in terms of prioritising research spending. But
okay, great point. Thank you. Have any other questions? If not, then
Well,
I'll...
you've-
Sorry?
Oh, that was me. Sorry.
Yeah, go for it.
Disrupting
You-
the rule
you
of
can
order
ask
here.
No, you can ask a question of anybody.
I'm reflecting because you're talking really about a systems transformation effort that's required to embed research into health institutions. And I want to respond to that too, just to make it really clear that when I was talking about that, the fact that I think that we have a mindset and a culture problem that's preventing community and consumer involvement happening more, I don't mean that any individual doesn't believe that their values align with that kind of way of working. That's not what I mean at all. I'm talking more about the structures, the way we do things, and our systems. So consumer involvement is not embedded as a normal part of how we do things at the moment, but rather it's been added on almost as a deliverable now that's expected. And that's one interpretation of a statement and guidelines, right? It can be that way. Sometimes there is an absolutely good reason to have a consumer reference group and a separate advisory committee and such. We were having a conversation about this last night. That is a thing that takes a whole lot of time, work and resources though, and that's not always required. If there's different ways of doing things, and I've seen huge success in different research areas where there's been teeny tiny changes, like when we have a journal club, there's an open invite, which is invite more people. Community members, consumer representatives who are working can come. Different ways of integrating, different ways of collaborating into what we already do in creative ways. Doing small, low-cost or no-cost things have brought a lot of value to research centres. So there's existing relationships when you suddenly see, oh, actually in 2 weeks I want to put a new grant in for a new idea, then it doesn't feel like you need to wait. It takes a whole lot of time. I've supported so many research groups to spend 3 months writing a terms of reference document to set up a committee. Absolutely. Doesn't take, like, we're creative problem solvers here. I think there's other things to draw on in terms of shifting systems and transforming systems so that, yeah.
So we've got to wrap up. I'll ask each of the panellists to actually make a decision on a question. It's an unusual thing for us academics to do. We'd like to discuss the varying shades of grey. But if we want to have an improved health outcome system in 10 years, which is the point of this panel session, is the best bang for buck for the community to better do and implement what we already have, or is the solution in a whole bunch of new tech, including AI and fancy new drugs? Which would you have if you're only allowed one? And I'll declare my hand. I'm representing the research translation centres, who would firmly be of the view that we should actually use the stuff we've already got now better, rather than necessarily fund a whole lot of new stuff. So I've made a decision. I've put my hand up. So you can't wiggle out of it, Steve.
Yeah, great question, and obviously it shouldn't be a black and white question, but you've asked it that way, and I'm going to answer it that way. I am very concerned that Australia will slip behind the rest of the world in terms of innovation and technology and new ideas. We're very good at digging things out of the ground and sending them overseas, but there are countries like South Korea and Germany and other countries that are clearly investing in innovation and doing it way better than we are. And we will just fall behind. So I would advocate new, and I love new things anyway, new technologies, and invest in innovation. And because I do think that science will underpin the sustainability of countries like Australia. I just give a little anecdote. I know we're running out of time, but Jeremy Farrar is going around the world talking at the moment. He's the new WHO chief scientist, was the head of Wellcome, arguing that low and middle income countries should be investing in science, and we should be helping them invest in science, because that's the way to make them sustainable and sustain their democracies. So I'm all for new science.
All right, so it's 1-1 for those that are keeping a tally. Gillian?
I agree.
I can see where this is going. I'm getting outvoted already.
We do need to still build on what we do, but to do new stuff, because there's lots of urgent problems. I think the situation with our climate is going to force our hand anyway. The old stuff's not going to work anymore.
Okay, great, Michael.
Yeah, I'm not going to be bullied into one or the other. I'm going for both. Because
there's no bullying in the academy. What are you talking about?
Well, that's what's going to happen. But I think that we do have to look at, as well as all the shiny, exciting things coming down the path, We do have to look at what we already know. And what do we already know? We knew when we're planning for our health system for the future that the biggest challenge we've got is inequity. And how do we make sure that our health services are available to everybody, both here in Australia, around the world, and the population groups who traditionally miss out. And with the new technology, the inequities are often confounded even further.
Okay, thank you. John?
Do I have the casting votes?
That sounds like it, yeah. It's
I mean, my take would be, we obviously need to keep investing in new technologies, but it's got to be targeted and informed investment, and that kind of relates to my previous point around prioritising research spending. And I guess I'd make a plug for health economics and health technology assessment, and the field of early health technology assessment, which is a formal field that pharmaceutical companies use all the time. They use elicitation techniques, they use modelling techniques to identify the pharmaceuticals and the indications for those pharmaceuticals that have got the greatest capacity for benefit and obviously from their perspective profit. But we can apply those methods from a public perspective as well, and I think we should be using them more.
Thank you very much. I won't ask for a vote show of hands because I can see that I'm a beaten man, but look, I'd like you to join me in thanking a terrific panellists for giving us a lot of food for thought. I'm not going to sleep for a long time, given you all, four of us have given us new opportunities to keep awake at night, but thanks very much for your contribution and for your efforts.